Assalamu alaikum, everyone. I would like to welcome you all in the 20th Annual Symposium of Shaukat Khanum Hospital. My name is Soban Ahmad Khan, and I am currently working as a resident pharmacist under the ASHP International Pharmacy Practice Residency Program at Shaukat Khanum Hospital, Lahore. I am delighted to be your host for today's Pharmacy Oncology session. The total time duration of today's session will be 2 hours and will be covered by 4 speakers, Dr. Rabi Dablis, Dr. Saima Qasim, Dr. Saba Mazhar, and last but not the least, Dr. Muhammad Umar Khalid. The chair of today's session is Dr. Muhammad Tahir Aziz Mughal, who is currently working as CEO, Chief Operating Officer at Shaukat Khanum Hospital, Lahore. He has been with this organization for about more than 20 years and continues to be an integral part of this organization. The co-chair of the session will be Dr. Umar Akhlaq Bhutta, who is currently working as Associate Director, Pharmacy Services, Shaukat Khanum Hospital, Lahore. He has been with this organization for about 20 years and is the most eminent personality here in the pharmacy department of Shaukat Khanum Hospital, Lahore. Before we begin with the presentations, I would like to inform the audience. If anybody has any question to ask, do write them in the comment section. It will be available to you below the presentation. We will be discussing these questions in the end as the session is about to end, and we'll begin a question answer session. All of your questions will be discussed there. Try not to become a man of success, rather become a man of value. Having said that, I would like to invite our first speaker of today's session, Dr. Rabi Dablis, Senior Manager, Quality and Medication Safety Services at Cleveland Clinic, Abu Dhabi. He will be presenting on the topic, Life Cycle of a Medication Event. So please welcome Dr. Rabi Dablis.
Assalamu alaikum wa rahmatullah. Thank you for those who have joined today's session. Today, I will be talking about the life cycle of a medication event. Medication event is a fundamental management process that you have to have in your organization in order to learn from good catches, near misses, or events that have occurred. The key learning objective for today's session is to list what are the elements of an effective event reporting system. So basically, what are the things that you must have in place as the core basics in order for you to be able to effectively manage and learn of these events. Describe the process of reporting and reviewing medication events, and identify some of the strategies that you can utilize in order to properly communicate the changes and the improvement that you have made to your system. When we talk about the elements of the safety culture, this is something that was described by James Reasons. It's an informed culture. So it is a culture that uses the most up-to-date information in order to make decision. It is a learning culture. It is a culture where you're always able to continuously learn from the events that are going on around you and able to make the necessary changes to your system. It is a just culture. And when we talk about just culture, it's when an event occurs, you're using a systematic way to investigate and to also make the right decision in terms of how do you want to handle the human component of the incident. You want it to be a flexible culture, meaning that you're able to adapt to the change as necessary. And then the last component of it, which we'll be focusing on today, which would be the reporting culture. You need to be able to find out what is going on in your organization, because the last thing that you want to do is to have a false sense of security and move around and say, oh, I only get 2 or 3 events per day, thinking that you are safe. It's the opposite. You want your 10, your 15, your 20 events per day, because think about it. You're prescribing hundreds of medications each day. You're verifying hundreds of medications per day. You're preparing hundreds of them. And then in your organization, especially in an oncology setting, these are very high risk medication, and it takes only one error for it to damage the life of a patient and also damage the reputation of an organization, and also the psychological safety of the individual that was involved in the event. Some of the barriers of the reporting that we see in different organizations is that the reaction to making an error vary. You are involved in an event, you might feel ashamed, you might feel extremely vulnerable. So you want to make sure that you are Not everyone's going to be comfortable reporting an event when it occurs. So you have to be mindful of that. Not every organization offers culture and psychological safety. So in some organization, you might feel that you're going to be penalized for reporting an event. So those might hinder people from putting an event in place. One of the things we push for is to really try to learn from these events and thank the individual who reported. Reporting isn't always seen as a priority. So some people feel that, okay, I've resolved the issue, I've taken care of it. Why would I need to put it in the system? It's going to be very time consuming for me. For some, the reporting process is too complex. If you have an event reporting system that is paper-based, that might take a lot of time to enter, write down the information. Instead of being able to copy and paste it from your electronic record, you'll have to enter manual it. It takes a longer time to process, and it doesn't allow you the opportunity to have proper analytics. And then a lot of the times what we hear is that, I entered the event, but I did not receive proper feedback. So why would I put the events? Everything that I'm putting is going to a black hole. So these are some of the things to keep in mind as barriers, and you can work around them and identify proper solutions in order for you to move properly with an event management system in your organization. So if one to summarize what would be the life cycle of a medication event, the first step, of course, is the event being reported. That can happen through a manual system, whether it's on paper or through an electronic system. I highly, highly recommend using an electronic system because it makes it very easy to enter the information, to track the status of where the event is. You're able to task it to various members of your organization. And then once you close the event, you're able to provide a loop back mechanism to the caregiver who put in the event. You'll also then you can do some analytics as well and see what are the trends, what are the medications we need to focus on. Do I have a caregiver who's been involved in more than one event that I need to coach and identify what is the reason behind this change in behavior. The second step after entering the event, you'll review and task it. So let's say I get a medication event through the system every morning or in the afternoon, whenever it's a 24-hour system. I look at the event. Sometimes it's an inpatient pharmacy event. Then I make sure that's tasked to the right individual on that team. Sometimes it's ambulatory. It can be a nursing administration event. So I make sure that the nurse manager for that area is aware of the event. So it's always tasked to the right individual. And you don't need, not everyone in the system needs to have access to it. Sometimes if it's someone who's only reviewing an event for like only once every 2-3 months, you can just send that to them through an email and that should be sufficient. The next step would be investigation and follow-up. And usually that is done by multiple individuals. It would be done by someone that could be part of my team, but it's also done by the manager for that area. And the reason behind the manager for the area being involved is that you want to make sure that the person who's overseeing an area is really aware of the things that are going on in their surrounding, so that they know there are trends, there are issues, that way they can address it, because they are the operational owners of that process. We will work very closely with them, but there needs to be that ownership in place. And so it's not really trying to juggle the ball. No, you take it, I take it. No, it's, definitely you want to work together, but also you want to be able to have one person who is owning the process. And then you will take the corrective action. You'll take it either individually or as a group, depending on the nature of it. And then the closure and the feedback. And you want to make sure that you shorten that process as much as possible, because the longer an event remains in the system, the less people are going to be able to really take a proper action with it. So all events that we see in our organization are reported through our event reporting system. And usually that's done in RL Solution. This is the vendor that we use, but you can utilize any other vendor. We have 3 categories of medication events: controlled and narcotics. So this is for all of the controlled. Let's say if an ampule is broken of any narcotic, then we have to report it to our Department of Health. The second category that we have is medication events. And the third one is adverse drug reaction. And the reason we have a differentiation between the medication event and the adverse drug reaction, it's different fields to enter when you're entering the event. It's also a different field that you need to do when you're providing the documentation. And we always make sure to remind the caregivers to preserve the evidence of a faulty product and send it back to pharmacy, because you want to make sure that you're able to visually inspect it. And then if you have the capacity to sometimes run analytic tests and see what's inside the product, if you have a suspicion that you have a faulty preparation, then you can utilize that as well. What are the things that we ask in an event? So when an event gets reported, we ask to use the SBAR methodology or communication style, which is what is the situation, what is the background, give me a brief assessment, and what are the recommendations. And according to the Institute for Safe Medication Practices, really the most important thing is to get a description of what happened. We went from having about 28 fields in our event reporting system that were mandatory. We brought it down to 13. There are some elements that need to be captured every single time, like the patient's name, date of birth, all of that. But what happened is the most critical piece of information. Just be descriptive, but be also very concise and straight to the point. Sometimes we get extremely long events. Those are hard to go through, and it's also time consuming for the reporter. So just, we ask for it to make it very, very brief. And then the other question that we will always ask them, what are your recommendations for improvement, especially when you're looking at a good catch? If you're someone who is in the organization who caught something that others are not aware of, most of the time you might have some good ideas on how can we make improvements to the system. Once an event gets reported, then I get a notification email depending on the severity. For example, here you'll see it tells you medication event subtype. Event resulted in temporary harm, required intervention. Most of the time, these can be if the patient requires an antidote because of an overdose on a narcotic or whatnot. So this is an example of what's in the system. All events, what will happen then, for all of the events, it will go to the unit manager for that area and the assistant nurse manager. It will go to the nursing director, to the quality nurse, to the risk manager, and then to the pharmacy manager for the area. So let's say if it happens on one of our acute or critical care areas, it will go to our director of pharmacy. And then it will, of course, always go to the medication safety pharmacist or the medication safety officer for the organization. And then it doesn't mean that every single person who's listed here is responsible for the event. There's always going to be the primary person who is the nurse manager, and then they will work very closely with the risk manager, the quality nurse, or the medication safety pharmacist in order to investigate and provide a solution for the event. And then if it's a very high event severity, let's say F and above, the categories that we follow in the UAE are from the NCCMERC, the National Coordinating Council for Medication Error Reporting and Prevention, and it's from A to I. So the A and the B are your near misses, and then the C and above are the more serious incidences. So if it's usually F and above, then it goes to the C-suite and to the legal team in order for them to know that a serious event has occurred, and then to anticipate that probably will be looking at a lot of corrective action. So what we do with the events is that a lot of the times, is that every morning we get a daily summary at 7 a.m. So as you can see in this calendar, Sunday through Thursday, which are our working days, we get a daily summary. In that report, we get all of the events that were entered in the last 24 hours. And then we also get the daily follow-up summary report. And I'll show you examples of those shortly. Every Sunday, we get a report of all of the events that have been open and how long they've been in the system. And then on Thursdays, we receive 2 additional reports, the 7-day summary. So it gives us the summary of the last events that happened in the last 7 days. And then also the follow-up summary report, which allows us to go back and see what have been the changes that were made in the event so we can start closing them. So here's an example of the morning event report that we get. So these are the events that happened in the last 24 hours. So we have a safety huddle in our organization, which is really a best practice to follow. So we review all of the events that have occurred in the organization, and we make decisions which are the ones that require immediate follow-up. The second report is the follow-up in the last 24 hours report. What this does, it shows you, these are the changes that were done in an event in the last 24 hours. This allows us to go in and then just sign them off. Let's say if you had 300 events in your system, you're not going to go back in and chase, open up every single event every single day to see whether a manager has made change in it. This will allow you to see, okay, manager X has made change. Okay, I can close the event right now. So that's in terms of reviewing the initial step of reviewing events. So when we do the tasking, so let's say here's an example of I've received an event. I have the categories A to I. We have the capacity to change it. A lot of the time, the end user might not necessarily, because they don't do this on a regular time, they might not know which category to select. We will add also the parties that were involved in the event. And we don't do this for any punitive reasons. It just allows us to keep track and to document what's going on. If I want to run a report and see, well, pharmacist X has been involved in 10 events, and I want to know the nature of those, because maybe they require some remediation and some additional training. And then we add here where were the event discovered and originated, because that allows us to know, well, okay, 60% of my events are related to prescribing, 70% are related to something else. We want to enter the event date and the incident time. And then what we have created on the other section here is the event summary. So what we'll do is we will take that long text and we will convert it into maybe 3 lines, and then follow-up summary to also capture what was the summary of the action that was taken. And the last part would be the feedback to the submitter, so that when we close the event, that field gets automatically transcribed to the email notification that the caregiver receives, and allows us to know what happened. And then as part of the investigation, we want to do a deep dive to better understand what is happening. And like I've mentioned before, it might involve the manager, the patient education, the physician. And one of the things that we have done added to our system, and you can have it depending on how flexible your system can be edited, is that we have a section that lists all the event managers and the unit who are covering for them. This is very, very useful to know who to task it to. One of the other things that I do, let's say, like I mentioned before, if a person doesn't have access to RL Solutions or event reporting system, what we will do, we will use a standardized email format. So the subject will say RLXX number, the number of the event, and then a brief description of the issue and the title. And then at the bottom, we describe the event. And if we are opening up an IT ticket, we have a section to, to also document the number of that IT ticket. This is very, very essential. So if you enter an IT ticket, make sure you document the RL solution. If you're required by regulatory requirements to submit it to a regulatory agency, and that regulatory agency gives you a confirmation number, take that confirmation number and put it back into your event reporting system. This closes the loop. This allows the individual who's going to be in your role in the future to have a full understanding of everything that occurred with that event. So this is really improves the documentation cycle. Here's an example of the different tier system that we use for IT. We generate at least 20 to 25 IT tickets every month based on the event. So we work very closely with our IT system in order to provide a solution. Sometimes it's a very easy fix. Sometimes it's something that might take several months to fix, depending on the complexity of it. And the fourth step is when we're looking at corrective action. And like I mentioned before, the best corrective actions are the ones that are forcing functions, where you have barriers and fail-safes when you're using automation and technology in order to restrict people from having access to things that they don't have access to. The medium leverage strategy would be having standardization, of course, and protocols in place, redundancy, warning, and alerts. But you don't want to go around and placing stickers everywhere you go, because then you can start having alert fatigue. You need to be very, very selective with the type of warnings that you use, where you want them, the format that you want to utilize, and then also the design of the document. And ideally, you want to remove the risk, limiting access to medication, providing smaller size and strength. Recently, in our organization, we received an external report. So it's not even something that happened with us, where there was a confusion between ondansetron and phenylephrine in an organization that resulted in the death of a patient. So we utilized this external event to go back and review the entire configuration of our automated dispensing cabinets in the OR, and we removed a lot of the vasoactive drugs that can potentially cause harm to patients if given in air. So it's not always relying on the internal events that occur in your organization, but you also want to learn from the external one. And the last step is closure and feedback. Event is usually updated with the details of the resolution and it's closed. And the caregivers will receive a notification that the event that they submitted is closed. And like you see in here, they'll click on the button and then it will take them to an area that shows the details of the event description and what was the feedback to the submitter. And also we have here a listing of all of the previously submitted events. So the caregiver has access to that information. So what do we do with the events? Externally, we are required to report a lot of those we are required to report adverse drug reactions to the Department of Health within 2 business days. We are also required to do the same for a serious harm event, and if we have any controlled or narcotic medication incidences. Over several occasions, we have submitted events to the Institute for Safe Medication Practices, and ISMP is a patient safety organization that works on advancing medication safety across the globe. So I really highly recommend that you submit events so that other organizations can learn from what happened, whether it's a good catch or an actual event. And like you see here, like I mentioned before, for an event that we have to submit to DOH, we enter the DOH submission date and then also the DOH reference number. So if in case we're audited, then we can show, well, the event occurred on this date, it was reported to pharmacy on this date, it was reported to DOH on this date. So it allows you to track also your performance. Internally, we have the Ismart Committee, which is the Interdisciplinary Safe Medication Management and Review team. That is a team that looks at medication events and medication management best practices and implements them. We report some of those events to the Quality and Safety Council. With the Quality and Safety Council, we do the annual review of events to learn from them. We see about 1,200 medication events per year. So there's a lot of a big wealth of knowledge to learn from. And then we provide safety brief to the organization in case we see there's something that everyone needs to be aware of or a specific group of people. And then we create the risk and project registry. So here's an example of some of the safety briefs. So the first one is the safety brief that we had with one of the connectors. Was leaking medications. We work very closely with the nursing leadership on this. As you can see, I utilize a standardized communication tool. On the top, it shows you the nature of the communication. So if it's something that's serious, I use the red upper body, the red coloring for the headline, and then I'm describing it as being a product safety brief. The second one is a product recall. The third one is just a regular communication. So you see the blue is in the headline, so it's not as serious. And then if you want to communicate something to the caregivers, again, keep it very straight to the point, bullet points, not a lot of white space so that people can easily read it. If there's an image to use, include it. And if there's a reference, we maximize the use of barcodes as well in order for people to better see what's going on. And here's what I mentioned earlier. We have a risk registry. So here we document in this Excel sheet all of the projects that we're working on and any communication we might have developed in response to the events. You want to celebrate your good catches. So share with the staff the learning opportunities. We have a good catch program that we're building up on the organization right now. Pharmacy was recently recognized for being one of the highest reporters. We will be celebrating them in mid-November in front of the leadership team. What our Quality and Patient Safety Institute does is every week we identify a caregiver who has been a high reporter or who had identified a good catch that resulted in preventing harm on a patient or on multiple patients. And then you want to create that recognition as well. It might create sometimes a healthy competition as well when people like to be recognized, different people at various degrees. So create a healthy competition sometimes between caregivers and between departments. And the last part, and this is a full session on its own, when you're investigating your event and when you're starting to deal with the individual that was involved in it, we utilize a structured process called the Just Culture Decision Tree. We have adapted this from the NHS and then and the Cleveland Clinic. So it goes over multiple questions. Did the caregiver deliberately try to cause harm? Were there any indication of a substance abuse or something that could have impaired their judgment? With other individual, is there a process in place? Is that process or is this policy something that's workable? Like sometimes you might have two different policies that are opposing in what they contain. Did the caregiver have risky behavior? And then, were there any other mitigating circumstances? As you go through that tree, then you can make a decision on how you can handle that incident. And we have developed a Just Culture video that we use part of the training. You can barcodes, you can apply you can aim your camera on this barcode and it will take you to the YouTube link. And a lot of organizations have been using this video to kickstart the conversation around Just Culture and medication safety. I thank you for your time and your attention, and I wish you a pleasant remaining of the conference.
It's hard to beat a person who never gives up. That was Dr. Debbie Dablis, Thank you so much, sir, for the highly thought-provoking presentation. Success is the sum of small efforts day in and day out. On that note, I would like to invite our second speaker, Dr. Saima Qasim, Senior Oncology Pharmacist at National Guard Health Affairs, Jeddah, Saudi Arabia. She will be speaking about pharmacy practice standards, the perspective of Quality Oncology Practice Initiative. So please welcome Dr. Saima Qasim.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Saima Qasim. I'm a board certified oncology pharmacy specialist and a board certified sterile compounding pharmacy specialist. I'm currently working as a senior oncology pharmacist in Ministry of National Guard Health Affairs in the Kingdom of Saudi Arabia. I started my career as a pharmacist from Shaukat Khanum Memorial Cancer Hospital and Research Center, and I'm glad to be given an opportunity to share my knowledge and experience as a guest speaker on this prestigious platform of Shaukat Khanum Cancer Hospital. The topic of my talk is pharmacy practice standards with the perspective of Quality Oncology Practice Initiative. Let's go through the disclaimer statement. I have no financial relationship to disclose. I'm not endorsing any product or services mentioned in my presentation. During my presentation, I'm going to talk about the expanding role of the oncology pharmacist, standardizations of specialized oncology pharmacy services, selecting from available standards, and the Quality Oncology Practice Initiative COPI certification program. Pharmaceutical care services is an integral part of any healthcare organization, and it has been divided into different areas of the pharmacy department, like ambulatory care, oncology clinical pharmacy services, quality and patient safety, inpatient pharmacy services, aseptic IV compounding services. And the role of oncology pharmacists in all of these domains is crucial in providing pharmacological medication therapy management in the cancer patients from the point of diagnosis throughout the survivorship. Now, why do we need standardized oncology pharmacy services? As we know that the cancer itself is a very complex disease, starting from the diagnosis of the disease, staging of the different types of cancers, then selection of the appropriate treatment plan, then complexity of the treatment protocols, new drug approvals by the FDA, targeted therapies, new immunological agents, and then adopting a cost minimization and cost effective strategies. All of these are the parameters which emphasize the development and adoption of the standard pharmacy practices. I'm sharing a report of Pennsylvania safety reporting database report from 2015, July to 2017. If we see that this report shows the highest number of the medication errors in outpatient hematology and oncology clinics were the prescribing errors, and followed by administering, dispensing, transcribing, and monitoring. And these are the chemotherapy medications which were involved in the highest number of the incidents reported. If we look at the timeline of the monoclonal antibodies, starting from 1975, when the first monoclonal antibody was introduced, till 2019, we see that the data is quite large, and which shows that there is a paradigm shift in treating cancer patients from conventional chemotherapy agents towards targeted therapies. So which again emphasizes the role of the oncology pharmacists in treating cancer patients. From the decade report of FDA from 2010 to 2019, it says that a total of 387 novel drugs and 27 biosimilar drugs are approved by the United States Food and Drug Administration. And among those, oncology remains at the top of the list with 25% of the total FDA approvals. So it includes like CAR T-cell therapies, bispecific T-cell engagers, anti-CTLA-4, PD-L1 inhibitors, anti-GD2 therapy. If we take example of blinatumomab, which is a bispecific CD19 directed CD3 T-cell engager, which is approved by the FDA in treating Philadelphia chromosome negative relapse or refractory acute lymphoblastic leukemias. And from the mechanism of action of the drug itself, which is complex, the dosing regimen is also complicated, depending on the weight of the patient, BSC of the patient, and then the infusion protocol itself over 24 hours, 48 hours, or 7 days continuous infusion. And then if we come to the compounding of the medication, it also has some specific guidelines to be used during the preparation of the blinatumomab. And then similar, there are some specific guidelines for the administration of blinatumomab and then management of the toxicities, which all emphasize that we need to have standard pharmacy practices. We need to have some extra checkpoints to ensure the safety of the medications for the cancer patients. So which leads to that expanding role of the oncology pharmacists and medication therapy management for patients with cancer from diagnosis throughout the survivorship. You must be involved in the development of the guidelines, policies, standards, and clinical pathways, providing direct patient care at the bedside, educating other members of the healthcare team on medications used in cancer care, stem cell transplantation, hematology, gastroenterology, immuno-oncology, and precision genomics are the advanced technological and advanced medications. And it's a separate huge domain or a huge specialty within the cancer specialties, which needs competent and well-trained oncology pharmacy staff. Aseptic IV compounding and advanced treatment preparation systems, and the role of the pharmacists involved in the cost minimization and cost-effective strategies and cost minimization strategies, pharmacy informatics, and automation. As working in a healthcare organization, we all try to adopt the best standards within our available resources, but we need to make sure that the care we provide to our patients is according or up to the acceptable standards. Where standards serve as the foundation of an evaluation process that can help organizations to measure, assess, and improve performance. And all these 4 parameters of an evaluation process are based or focused on the patient safety and quality of life. In a competitive from the commercial point of view, the accreditation provides a competitive advantage, and it provides individual assurance that you are providing a quality care and you have competent staff. And it also identifies that the organization is being progressive and thinking forward and keen for the improvement of the provision of quality care to the patients. And these are different organizations which certifies a healthcare or a healthcare system: JCI, COPE, ASHP, and Commission on Cancer. COPE is particularly specific to the oncology practice standards. ASHP accreditation is considered the gold standard which all of the pharmacy practices aspire to achieve, and it's the sole organization in accrediting the pharmacy residency programs since 1962, and the accreditation of the pharmacy residencies is an excellent driver in improvement, and it serves as a bridge between the pharmacy practice and education. And I would like to take this opportunity to congratulate the pharmacy department of Shaukat Khanum Cancer Hospital on achieving this landmark accreditation of ASHP residency pharmacy residency program. I wish you all the best for your future as well. And the next is that the certification program provides a 3-year certification recognizing high quality care for outpatient hematology and oncology practices. Now, the benefits of being COPE certified are that it gives you a reputation that you are a champion of quality care, and access to quality and safety standards being specific to the outpatient oncology setting, a fostered culture of excellence and self-examination, intend to reduce the risk of errors when providing chemotherapy to patients with cancer, practice improvement with the demonstration of quality and improved efficiency and effectiveness. The COPE certification program has certified over 300 practices across the United States, Brazil, Greece, Spain, and Romania. And King Abdulaziz Medical City Central Region is considered as the first organization being accredited in the region of Asia in May 2019. The certification standards for the COPE certification program are based on these 3 components: the development of the policies and procedures with the observation of the process flow and the documentation by the patient satisfaction surveys. And these are the parameters which are based to develop the COPE certification standards. There are more than 140 measures in the COPE program strive to reflect the team-based care provided to patients with cancer in the outpatient oncology setting. And these are a few parameters or a few measures I am sharing with you. And all of these measures help the practitioners and the clinical pharmacists and therapeutic decision-making. For example, the colorectal cancer patients, the RAS testing for patients with metastatic colorectal cancer who receive anti-EGFR monoclonal antibody therapy. And if the KRAS NRAS is wild type, then the patient is eligible to receive the anti-EGFR therapy. So these parameters will help the practitioner to select an appropriate regimen for the patients. The COPE certification standards have 4 detailed defined responsibilities, and within each domain there are certain standards, and within each standard there are some elements which provide more specificity to the particular standard. So I'm going to discuss the domains which are more related to the pharmacy practices. As in this domain, it's clearly mentioned that the role of the oncology pharmacy is very crucial and important in any oncology center, and it states that chemotherapy is prepared by a licensed pharmacist, pharmacy technician, physician, or a registered nurse with documented comprehensive chemotherapy preparation education, initial training, and at least annual continuing education and competency validation. So in this domain, the documentation of the initial training and the competency validation is very important. As we discussed earlier, that in the ISMP report of 2004 to 2011, the highest number of the medication errors, as we discussed that in the Pennsylvania report of the safety reporting database systems, that the highest number of the medication errors reported were the prescribing errors. So this domain is important and defines in detail the requirements for the chemotherapy order sets, verification, labeling, and safe handling and extravasation procedures, which says that the chemotherapy orders must have all the following 16 elements to minimize the risk of medication errors at the end of or the point of prescribing. And if we need to make sure that the software we are using is helping us to develop all these elements in the built-in chemotherapy order set. And for example, cycle numbers are important in certain cases, like if the protocol, for example, I will take the example of AC protocol followed by weekly doses of paclitaxel. So 4 cycles of AC followed by 12 doses of paclitaxel. The protocol should be built in a system that the system will automatically select and schedule the number of the cycles for the patient. And similarly, if there is for example, in the protocol of trastuzumab and pertuzumab, the first cycle is with the loading dose of trastuzumab and pertuzumab, and then followed by the maintenance doses of trastuzumab and pertuzumab in the breast cancer patients. So the system should be supporting the incorporation of all these elements in the standardized chemotherapy order set to minimize the risk of errors associated with the prescribing. Before preparation, a second person, practitioner, or other personnel approved by the healthcare setting to prepare or administer chemotherapy independently verifies 2 patient identifiers: drug name, dose, route of administration, rate of administration, the calculation for the dosing, including the variables used in the calculation, treatment cycle, and day of cycle. Sometimes the auto calculation feature of the software itself is a contributor to the medication error. If the wrong height and weight is documented in the system, it will auto calculate the wrong dose for the patient, which is also sometimes leading to significant medication errors. So the verification and independent double-checking procedures must be regulated by standard policies and procedures, which making sure with the supplementation of the training programs and continuous education programs to assure the maintenance of accuracy and quality. In ISMP report of 2004 to 2011, it states about very serious compounding errors involving 16 patients, out of whom 9 patients died because of the wrong concentration, wrong product, or wrong diluent used. So which emphasize the importance of this standard of domain number 3, that during the preparation, all these parameters must be independently verified to avoid the risk of compounding errors. So after preparation, during and after preparation, the final product must be double checked by an independent pharmacist who was not involved in the preparation, and he will compare the final product with the original prescription of the chemotherapy as well as the preparation worksheet or the compounding log sheet. Some practices are using the chemotherapy compounding logs or work cards or chemotherapy cards to document each step during the compounding of the chemotherapy medication. And we can use technology to augment the manual processes. Technology can provide surrogate checklist in verifying and independently verifying all the steps of the preparation as well as the dispensing, which may include the IV barcode scanning, gravimetric verification or scanning of the ingredients, and IV workflow systems and IV robotics. But all these technologies can be helpful in augmenting the manual process, because still the independent double check or the manual independent double check provides an important tool in error detection and error prevention. The medication label design is also an important contributor to medication errors. So the components and the formatting of the label should be in a way that it provides a systematic checklist of all the components which are essential to be in the label, as the copy mentions clearly that the following 10 elements must be a part of the chemotherapy label, and it should be labeled immediately upon preparation. So all these components provides the systematic check to ensure the safe administration of the chemotherapy. In chemotherapy administration via the intrathecal route is also important in certain chemotherapy regimens, and being high alert, being the route itself being the high alert, that for example, the Winca colloids being given through intrathecal route can be fatal. So the intrathecal administration of chemotherapy medication policy needs to specify that storage, the handling of the intrathecal medications should have all these 5 elements mentioned in the COPI standards. And because in the ISMP 2015 to 2016 to 2017 updates of ISMP states that the Winca alkaloids, because of the risk of the inadvertent administration of intrathecal vincristine, we must prepare the vincristine and the other Winca alkaloids in an IV piggy bag or infusion bag to minimize the risk of intrathecal administration of vincristine. And we are already in our organization, we already started this practice since 2016 on the updates of the update release of the ISMP. So the policies should clearly specify the storage and handling of the intrathecal medications. After chemotherapy administration, the patients are at a risk of serious adverse effects and sometimes potentially life-threatening side effects. So the standardized documentation of the dose-limiting toxicities and the cumulative doses of the chemotherapy agents and the review of the patient adherence is very important in monitoring of the dose-limiting toxicities. So this domain provides the foundation of monitoring of the patient and the documentation of the toxicities of the chemotherapy agents. So it states that the patients must be monitored after the chemotherapy is given, including adherence, toxicity, and complications. So the adherence is one of the most single important factor in optimizing the best outcomes in patients' treatment, and maximizing the adherence of the oral chemotherapy agent not only ensures the improvement of the overall survival and life expectancy of the patient, but also the safety and quality of life of the patient. Adherence, where adherence is a dynamic link between the provider and the patient himself, and it can be enhanced by involving the patient during the discussion and engaging him while making the decision of the treatment plan. And the significant barrier in monitoring and recording the cumulative doses of the chemotherapy, at least but not limited to the anthracyclines, doxorubicin, daunorubicin, epirubicin. And the significant barrier is that the data is not readily available for the cumulative dose of the chemotherapy. So we must develop a policy or procedure or some protocol in which we can easily retrieve the data for the cumulative dose of the chemotherapy, which is usually not available in most of the electronic health records. Maybe it can be developed or built in the system, or manual documentation of the cumulative doses to make sure about the to prevent the dose limiting toxicities of certain medications. So during my presentation, we have already discussed that the pharmacy practice standards serve as a framework for the program and a guide to the best pharmaceutical care services and oncology settings. To be a champion of quality care, develop a workplace culture that fosters excellence and self-examination, leading to improvement. COPE certification is a significant achievement for any organization and offers many benefits to oncology care team, demonstrating a commitment to quality for patient safety. If you have any questions or queries, you may wish to contact me. You can contact me via email. And thank you. Have a nice day.
So quality in a product or service is not what you put into it. It is what the client or customer gets out of it. So that was Dr. Saima Qasim. Thank you so much, ma'am, for your valuable time. Just for the audience, I would like to repeat once again, if anybody has a question, kindly do mention it in the comment section below. We will be discussing it at the end in the question answer session. A leader is one who knows the way, goes the way, and shows the way. In that spirit, I would like to invite our third speaker, Dr. Sabah Mazhar, Assistant Manager of Pharmacy Services at Shaukat Khanum Hospital, Lahore. She will be presenting on the topic, Hospital Pharmacy Management Skills and Effective Leadership in Pakistan, the ASHP Perspective. So please welcome Dr. Sabah Mazhar.
Assalamu alaikum. Good day, everyone. My name is Sabah Mazhar, and I'm working as Assistant Manager Clinical Pharmacy and Residency Program Director at SKMCH Lahore. So I have no actual or potential conflict of interest in relation to this program or presentation, and pictures used in presentations are for educational purpose only. My first question with you all are that why leadership is so important? Why everybody is talking about leadership? And what is the thing that is holding you back? Is that your excuses? Is that your stories? Is that your bad behavior? Is that your bad habits? Is that your fear? Is that about your stories? What is the thing that is holding you back? And sometimes the thing that is holding you back is just in your head. And maybe you are working very hardly, but maybe you are not working smartly. And sometimes you are just focusing the problems while missing the solutions. So that's why leadership is important, because it will help you to broaden your vision. It will help you to broaden your thinking. It will help you to how to do the right things at the right time. And it's all about to mapping out where you want to go to win as a team, as an organization. So that's why leadership is important. And without leadership, everything will be empty. You cannot get anything from an empty. For example, if you get E from empty, it will still empty. If you will get Y from empty, it's empty. If you will remove P from empty, it will still empty. So empty will remain empty. And without leadership, everything will be disorganized. Let me read this paragraph for you. So according to research at Cambridge University, it doesn't matter in what order the letters in a word are. The only important thing is that the first and the last letter be at the right place. The rest can be a total mess and you can still read it without a problem. This is because the human mind does not read every letter by itself, but the word as a whole. So that's what I'm saying. Maybe something is looking good, but collectively, but without leadership, it will be disorganized. So that's why leadership is important. You can see some numbers from 1 to 100 on the screen. I will ask all of you to please select one number from these 1 to 100 numbers. Now I will move on. How many of you will actually remember that what was the number in front of your selected number? How many of you? Maybe 50%, maybe 80%, maybe 100%, and maybe 10 to 20%. So what is missing? What is missing? The thing that is missing is focus. So we need to focus collectively while doing multiple things. So leadership is not about the next generation. It's not about another hour. It's not about another week. It's not about another month. It's not about another year. It's actually about the next generation. So you will work for your next generation. So take a step, be forward, and take your responsibility. There was a girl in 2005 named Sarah White. She did some research that indicated that there will be a significant gap in pharmacy leadership in next 5 to 10 years. She also said that 75% of pharmacy directors anticipate leaving job within 10 years. Why this is so? Why they are leaving their jobs? If they will leave their job, then what will happen? So Mike Hunt says that a lack of leadership means that the health system pharmacy will no longer be in a position to enhance patient safety, to optimize medication therapies across the continuum of care, and to make a real difference in the lives of the patients that we serve. So that's why leadership is important. Who will step into the plate? A pharmacist, a physicians, nurses, therapists, respiratory therapists, other healthcare professionals. Who? What do you think? That these healthcare professionals think about the pharmacy profession? Why? Why they will think about pharmacy profession when we are not thinking about our own profession? We are not thinking about our own profession. So what will happen? What will happen to that? How do you feel about non-pharmacists leading our profession? That will be a disaster. So please come forward, take your responsibility against your profession, be a leader, and produce more and more leaders. Come forward. There's also a ray of sunshine that she stated that 63% of the students convey on leadership, surveyed a leadership position in their future. So what we will do for this? For this, we will have to understand the true meaning of leadership. So leadership is influence, nothing more and nothing less. It's a developing vision of a goal that is capable of capturing and sustaining the commitment of the followers. And most of all, leadership is about making others better as a result of your presence and making sure that impact lasts in your absence. So let's start changing pharmacy practice. But first of all, we'll have to understand the challenges of leadership and what is the actual situation in Pakistan. I'm sorry to say that in Pakistan, we have a weak healthcare system with limited budget capacity. The pharmacy profession is on the brink of impending leadership crisis and the lack of young leaders. There's a very old Drug Act and regulations, that is 1976, in the Pharmacy Council. Pharmacy practice opportunities changes or challenges and lack of structured practice training programs. For example, pharmacy residency programs. We do have pharmacy residency programs in Pakistan, but they are actually not structured, and the medication safety. So let's begin with the end in mind. To begin with the end in mind means to start with a clear understanding of your destination. It means to know where you are going so that you better understand where you are now and so that the steps you take are always in the right direction. For this, you'll have to understand the types of leaders. So there are multiple leaders. Leaders by the position achieved, by personality charisma, by moral example, by power held, intellectual leaders, and leaders because of ability to accomplish things. And leaders always provide guidance. They have a ready-made solution in their mind. They have a broad vision. They always believe on teamwork. There are multiple directionals. They have a good strategy. They have very good in communication, and they have a pinpointed goal. So if you want to be a next generation leader, There is a practical tip that consists of a 4-step. The step 1 is to develop a plan. Step 2 is get involved into it and seek out the career goals. Step 3 is leverage a mentor. Step 4 is build your leadership skills. So one by one. Step 1, develop a plan. Develop a 1 and a 5-year plan. Start writing. List the things that motivate you. List your knowledge, skills, and experiences. Create a mind map as a guide while thinking about your knowledge, skills, and experiences. Then step 2 is get involved into it, explore your career options, seek out a unique internships and leaderships and rotations. While thinking about pharmacy administration, informatics, clinical management, and medication safety. You can meet a pharmacist practicing these areas of interest. You can also attend the state and national organization meetings. You can get involved in with the research or publications. You can also serve as a volunteer or a shadow as a pharmacist. So build a CV, one brick at a time, step by step. Step 3 is very important, leverage a mentor. Look, it is not always important that what you know, but who you know that really matters. So seek out mentor, be a good mentee, because mentors will actually help you to identify the endpoints and assist you creating your plan. Step 4, build leadership skills. You can build leadership skills in journal, in clinical and administrative levels. But the point is that where you can learn these skills. So with this, I would definitely motivate you to consider residency trainings. Why residency trainings? Because residency trainings produce leaders and you want to be a more effective leader. It will help you to practice skills that you have learned in the school. It will help you to learn from the top practitioners. It will provide you a career flexibility through broad experiences. It will give you an idea of self-awareness through feedback and coaching. And it will definitely refine journalist leadership skills, that is time management, communication, and professionalism. There are 2 categories of pharmacy residencies. The first one is postgraduate year 1 PGY1 residency. That can be on hospital and in ambulatory care and community pharmacy practice, and it will provide you a broad clinical knowledge and some exposure to the leadership. The second one is postgraduate year 2, that is PGY2 residency. It's basically in a specialty training. It provides you intense and focused training. It's a specialty training. So why consider pharmacy administration as a career? Because it will provide you opportunity to influence patient care on a large scale. And it will provide you an ability to lead important initiatives to advance a pharmacist's scope of practice. It will also provide you an ability to influence direction, funding, and implementation of clinical programs. It will definitely make a difference in the lives of our patients. So that's why you can consider pharmacy administration as a career. And why you will consider International Pharmacy Practice Residency, IPPR, because it will provide structured training program for pharmacy practice in view of international standards. It will provide leadership skill set addressing of current pharmacy challenges and demonstrated how residents are equipped to face these challenges. And it will definitely focus on the importance of engaging in self-reflection, advancing the profession, seeking leadership opportunities, and maximizing resource utilization to accomplish career objectives. So that's why you will consider International Pharmacy Practice Residency. Now, SKMCH residency program. I can probably say that Shaukat Khanum Memorial Hospital, Lahore is the only second non-US hospital in the world whose residency program is accredited by American Society of Health System Pharmacists and is the first IPPRP ESHP in Southeast Asia. So here's a residency program at a glance at SKMCH. It's a 1-year program with 2 residents at a time, 16 learning experiences, or you can also say specialties, rotations, longitudinal experiences. These are the experiences that will go throughout the residency program. 6 competency areas in which our residents will be trained. A quarterly preceptor development plan, resident development plan, summative assessments at the end of each learning experiences, formative assessments or regular feedback, research project, and finally, residency certificate. So learning experiences, as I told you, basically are the specialties in which our residents will be trained that will start from orientation, then management and leadership skills, then quality and patient safety, then ambulatory care, aseptic services, total parental nutrition, and drug information. After that, our resident will be entered in a direct patient care services, that is internal medicine, critical care, infectious diseases, surgical services, adult oncology, pediatric oncology, and palliative care. Then starting sport and research projects are two longitudinal experiences that will go throughout the learning experiences. All of these learning experiences, if I go back in 2019, when we were seeking for the residency accreditation, so we have only 12 learning experiences at that time, but just after getting accreditation from ASHP, we have added 4 new learning experiences that are quality and patient safety, internal medicine, surgical services, and staffing support. And all these learning experiences are trained under the competent pharmacists. We have 4 American board certified pharmacists who are currently working in SKMCH. So these are the competencies areas: practice foundation and leadership skills, drug information, medication policy and medication safety, practice management and leadership, patient care, education of others, and project management. And all these competency areas will be trained with the modern teaching methodologies of direct instruction, role modeling, coaching, and facilitating. How you will apply for International Pharmacy Practice Residency Program of SKMCH. So SKMCH always advertise their residency seats, usually at the start of every year. You can apply from these channels. These are our residents: Ms. Hamail Khalid, Mr. Fahad Javed, and Ms. Zara Hashmi are currently working with SKMCH. So our journey together towards excellence. I would definitely like to share some of our memories with you. This is our team, our SKMCH pharmacy family. Symposium team, the celebrations, meet the family of SKMCH, and the journey continues. Thank you so much.
Leadership is about vision and responsibility, not power. Very well said. That was Dr. Sabah Mazhar. Thank you so much, ma'am, for your valuable guidance. In a gentle way, you can shake the world. So by saying this, finally, I would like to invite our last speaker of today's session, Dr. Muhammad Umar Khalid, Pharmacy Manager at Burjeel Hospital, Abu Dhabi. He will be talking about the role of pharmacy according to updated Joint Commission International Standards. So please welcome Dr. Muhammad Umar Khalid.
Hello everyone, my name is Omar. Currently, I'm working as a pharmacy manager in private sector Abu Dhabi. Today, I'm going to speak about one of my favorite topics, digitalization in healthcare. It is fast growing and a highly demanding field right now. I have no financial relation to disclose. Before I start my talk, I would like to invite you all for our upcoming conference, European Conference of Oncology Pharmacy, which is organized by European Society of Oncology Pharmacy. So please mark your calendar. This is my current working place, Burjeel Medical City, multi-speciality 400-bedded hospital in Abu Dhabi, and this is the only ESMO accredited hospital in UAE. We opened our door in March 2020 with the management of COVID-19. It was a huge challenge with great learning experiences. Later on, we people declared as a COVID-free facility, and then we start our phase-wise launch. Initially, we people establish our long-term rehabilitation, then comprehensive oncology, and later on, we converted our urgent care setup into emergency department. Our integrated pharmacy module has a pharmacy store, outpatient pharmacy, inpatient pharmacy, pharmacy satellite pharmacy, and medication room. Scope of services include administrative services like research and educational services, And then the ownership of the committees like a Pharmacy and Therapeutic Committee, Antimicrobial Stewardship Committee, and then the Pharmacy and Nursing Committee. And we people are also playing a role for the implementation and development of the electronic health record and the automation. We have a comprehensive pharmacy compounding program. It includes a non-sterile preparation as per USP 797, 795, and sterile preparation as per 797 USP chapter, and a hazard preparation as per USP 800. Then clinical pharmacy services and the general pharmacy services. JCA, Joint Commission Accreditation. Everybody knows that it has 16 chapters. 88 chapters are patient-centered and 6 chapters for the management and organization and 2 chapters for the academia. Pharmacy has a ownership for one of that chapter called MMU, Medication Management and Use. It has 7 standards with expansion, 20 standards and 82 mating elements. It is applicable across the hospital where the medication are stored and used. The goal of MMU is to develop and implement the medication management system, compliance with the local regulatory authorities, and to support the patient safety and to improve the quality of the care, and to define the any educational need for the healthcare professionals and the patients. Why digitalization? Why world is running behind the automation? Is it an innovation? That's why no. The answer is no. As we have already discussed, like the goal of MMU is increase the safety, reduce the healthcare cost, and create some efficient process for the pharmacy. So this data shows that the current practice of the MMU has some gaps, so significant opportunity exists to improve the medication management. So automation is an option, and which is a good option. In some countries, the automation it is becoming a government mandate under a program called Medication Artificial Intelligence Powered Program for the Excellence. The one of the basic requirement for the art pharmacy automation is the Hospital Information System (HIS) or Electronic Health Record (EHR) with the comprehensive pharmacy module. Pharmacy module can be a separate, but it should be capable for the HL level 7 integration, and it can address the RCMA revenue cycle management and clinical features and the operational and regulatory compliance. And this will help to determine the which level of automation we people are able to achieve. So normally there are 5 level of automation. Moving forward, I will discuss the 7 standards of MMU with the data-driven pharmacy operation and end-to-end automated medication management. MUM 1, organization and management. The Pharmacy and Therapeutic Committee will be a lead of this chapter. The new normalcy or during the management of COVID-19 is that the normal in-person meetings are converted into online meetings via Google or like Zoom or the Skype corporate. In addition to this one, Monday.com or the Microsoft powered artificial intelligence feature called My Analytic is playing a vital role for the establishment and organization of these meetings. Role of PTC is to establish and manage a medication formulary. Management of Medicaid formulary includes the addition of medication drug alerts like response to drug recall, drug shortages, and the periodic pharmacy review. New upcoming feature of several electronic health record is that the availability of a dynamic form on their web page for the addition of new drug. The idea behind this is like the medical representative will fill that form and will attach the necessary attachments. They will also provide the codes like the GSC1, GTN1, municipality registration code, as well as the MOH registration code of those drugs. Then the artificial intelligence or machine learning feature of that HIS will review and compare that data in comparison with the previously available brand for that particular drug. Then this will create a pharmacoeconomics and the clinical analysis report. That report will be shared in the PTC. After approval, that the request for that new drug will be forwarded to a purchase team for the supply chain management. A MMU 1.1 integration of stewardship into electronic health records. Still, it is a challenge for a lot of well-known EHRs. So AMS monitoring basically includes tracking and prescribing and the resistant pattern of antibiotics, the optimal and the prophylactic antibiotics, the minimization of a verbal AMS approval, and evidence-based documentation. MMU tools, selection and procurement. Pharmacy software is also point of sale, and it is required. It should have procurement management, supply chain management, inventory management, BI reports. Moreover, stock forecasting and the consumption reports and the lead time for the supplier performance alerts help us to optimize our physical pharmacy stock as well as to maximize the return on investment. The third one is the storage. Upon receiving a stock of medication will be displayed in the traditional racks. But now in the era of automated pharmacy, the robotic cabinets are available. Some examples includes a BD Rova, Omnicell have developed a Narcvault and that Mac 4, and for the Unidos pre-packing machines, they are also available in the market. The automatic dispensing cabinet has a feature like a prescription review, submission of insurance approval, billing panel, the distribution of the drugs at the dispensing counter. Automatic dispensing cabinets are increasing the safety and the security of the medication, as well as the paperless documentation is adding an additional benefit. ISMP has already issued some guidelines for the implementation of these automatic dispensing cabinets. It is a full-time project, and most projects finish at the end of the implementation, but the pharmacy project start with it. MMU for prescribing or the transcribing the implementation and that use of the electronic health record helps us to set and the control the prescribers privileges, who can prescribe what and for how long they can prescribe. Also, availability of automatic stop order is adding the additional benefit in the safety of the medication use. A second advantage from the EHR is the enable us to ensure the completeness of the medication order. A complete medication order has a patient demographic as well as the drug attributes. In order to make the prescribing more user friendly, the ISMP has introduced an idea called order set. Order items are used to create order set, and these order sets are used for the formation of several protocol and the clinical pathways. The third benefit from this physician order entry system or the implementation of EHR is the electronic medical reconciliation. Here in UAE, in the capital of UAE, all the HIS are connected with the National Health Database called Malafi. So it is helping the physician to do a medication reconciliation at the time of hospital admission or the transition of care as well as discharge. So for the medication reconciliation information from these resources plus the structured data from coding resources like ICD-10, then the display of drug information from the formulary and clinical decision support system are playing an important for the safe and effective computer physician order entry system. MMU5 is a preparing and dispensing. This is an example of a paper-based life cycle of dispensing. Pharmacists will receive a handwritten prescription or a marker, and then the manual label preparation and packing, followed by a semi-electronic billing will happen. This is a paper-based and the human-dependent process. Research shows that the medication errors are more with the human-based process as compared to a computerized process. Let's see how safely medication can be dispensed in automated pharmacy. Upon receiving an order, the medication order will be reviewed and the clinical appropriateness order will be maintained. After that, the order will go for the mapping process, and it will let the pharmacist to do a generic substitution, and upon completion of that generic substitution, pharmacist will be able to generate a computerized label with the barcode. By using that barcodes, the staff can collect the right dose of right medication from the automatic dispensing cabinet. In case of IV admixture order, the order will be followed for en route to the IV workflow system, and which will help us for the preparation, the verification, tracking, and documentation of sterile compounding products. The well-known brands for this IV admixture are the Baxter, BD, Omnicell, and grease your fill. Manual drug cards for the distribution are going to be replaced by the pneumatic chutes, and they have a tracking and tracing feature, and these features are similar to that what the courier companies are having. The number 6 is administration of medication, and this is basically for the nursing module. I have observed biggest challenge for the nurses is the paper-based documentation. So now availability of a pre-developed or predefined checklist with voice text feature in of the HIS, helping the nurses to complete their documentation smoothly. And the utilization of the closed loop BCMA is also, where the infusion pump is also useful for the administration process. Implementation of infusion pump, again, this is a like a full-time project, and the biggest challenge will be the integration with HIS. The role of pharmacists is the development and the validation of the drug library and the staff training. The last standard for MMU is the monitoring and education monitoring. Monitoring has two parts: the collection of the data and the reporting, analysis and reporting of the data. Paper-based forms are already replaced by pre-filled dynamic forms, and the same forms can be used for the reporting purpose of the pharmacy interventions, adverse drug reaction, and the medication errors. The second part of this MMU 7 is education and research, so that out of 100 prescriptions, 50 to 70 prescriptions reach to pharmacy, and out of those 48 to 66 prescriptions are picked by the patient, 20 to 30 prescriptions are taken properly, and then 15 to 20 are refilled. So the drugs doesn't work in a patient those who don't take them. So in order to increase the adherence or the utilization of the medication, we people need to educate the patient. And for that purpose, a lot of hospitals, they have their own mobile app or the patient portrait. And that portrait is used for the telepharmacy services. Mobile apps, they have the full medication profile, administration instruction, medication photos, and as well as the most important thing is the direct communication with pharmacy. 7 months ago, I realized that the biggest challenge for the pharmacy automation is the data handling of the data, and the same data will use for the flow of information for integration and for the interoperability. This flowchart is available on my LinkedIn profile. If somebody is interested to read in data, they can review that one. In second Pharmacy and Innovative Conference organized by the Giving Back to Pharmacy in Pakistan, Dr. Isman has presented that the digital healthcare current status in Pakistan, and he has mentioned that there is a lack of well-developed HIS, and which is a core part for the implementation of pharmacy. So conclusion, your pharmacist may not be a human being, and the new types of pharmacies will be automated pharmacy with the less manpower influence. E-pharmacy, a pharmacy is having a paperless operation, or virtual online pharmacy, a pharmacy with the least infrastructure requirements. So this is an era of informatics. Try to become an informatic pharmacist. Thank you so much. I'm happy to take some questions.
If your actions inspire others to dream more, learn more, become more, or do more, you are a leader. So that was Dr. Muhammad Umar Khalid. Thank you so much, sir. So as we are done with the presentations, I believe we have the panelists here. So let's begin with a question and answer session. Kindly unmute the mics, please. Okay, so I have the first question for Dr. Saima Qasim. Is she here? Dr. Saima, could you hear me?
Yes, I can hear you.
Okay, so the first question for you is copy audit applicable on pediatric population?
This was actually based for, basically this was for adult oncology and hematology clinics, outpatient settings, not on pediatrics.
Okay, right, thank you. There's another question for Dr. Muhammad Umar Khalid. The question is how to develop culture of safety like JCI in government hospitals of Pakistan.
Thank you so much for the question. Shamas, as I know, like in Pakistan, we people are having a healthcare system called service-based. It is not like a value-based service system as we are having in the NHS or the European system. So if we are having like a service-based system, so we people can say our model will follow like the first primary pillar for the healthcare sector will be a revenue generation, then second will be a continuation of the operation, and the third will be the quality. So it's mean in our country quality which is the least. And in that case, what I can suggest, like we people can start from the implementation of the MMU. And as I have mentioned, like the HIS is a primary like pillar for this one. So in that case, again, the HIS, well-developed HIS is not available, as I just came to know from a lot of people. Shaukat Khanum, they are providing some Oracle-based system, which is shared with our multiple specialty hospitals as well. So again, if the people they don't have a buying capacity for that one, they can go for the development of some calculators and chart on the Microsoft Access or the some other software. So in that case, step by step we can achieve, and we can start with the implementation of FMU, and then we can move forward.
Right, right. Thank you so much, sir. Okay, so as we don't have any further questions, so I would like to invite Dr. Tahir Aziz Mughal to kindly conclude the session.
Okay, thank you very much. Can you hear me?
Yes, sir, we can hear you.
Okay, thank you very much. MashaAllah, very strong presentations from all, worthy speakers. Interesting to learn about many new things and happy to see new emerging leaders in the pharmacy profession. So I thank you all worthy speaker from the bottom of my heart for taking time from your busy schedule to be the best guest speaker at our oncology pharmacy SKMCH&RC Symposium. So all speakers' medication, presentations were very well. I just highlighted a few of things. Mr. Rabi have discussed medication safety human cycles, and he discussed the importance of the medication even in the patient safety in terms of optimization of medication therapy. It brings up a very new knowledge and refreshes the event of how we tackle and how we review this. Then we have Ms. Saima Qasim. She discussed and highlighted the pharmacy practices standard with the perspective of COPI and their importance in the quality of cancer treatment. Specifically, she discussed the role of pharmacy in chemotherapy, medication review and verification process, starting from the ordering of chemo protocol up to the administration and monitoring as well. Then we have a very good session from Sabah. She discussed about pharmacy management, and she discussed very good things on leadership. And later she discussed on ASHP program in Shaukat Khanum. And then lastly, we have a very good presentation from Omar Khalid on medication management and use processes and how the JCI actually emphasizes the importance of medication management and use system in optimization of patient safety in terms of medication therapy. So obviously all speakers present were wise words, helped magnify our cause in the best possible way for uplifting the hospital oncology pharmacy services in the region and specifically in Pakistan. So I'm very happy that our symposium is a huge success. All thanks to your enlightening words that inspired and gave insight of advanced pharmacy services. And inshallah, I'm looking forward again to all of you. Lastly, I would like to thank you to my pharmacy team of SKM Law who did well. How they manage all the session. So inshallah, I look forward to our next interaction soon, inshallah. Wishing you all the best for your future endeavors. Thank you very much.
Thank you so much, sir. So what a wonderful opportunity this was to connect with all of you. Behind every successful event, there is a team made up of ambitious and hardworking people. So again, I would cordially thank all of you, all the speakers, the team, the symposium team, and everyone. Thank you for joining and being a part of this session. Thank you so much. Allah Hafiz.
MashaAllah. Thank you very much.
Thank you.
Thank you. Thank you.
You're welcome. Allah Hafiz.
Allah Hafiz.